Hello, everyone, and thank you for joining the healthcare workshop of the National AAPI Leadership Summit. This evening's workshop will discuss the challenges and inequities Asian Americans, Native Hawaiians, and Pacific Islanders face in accessing healthcare and the policy priorities to improve health delivery and outcomes for our community, particularly in a COVID-19 world. This workshop is part of a series brought to you by API Vote and the National Council of Asian Pacific Americans. I'm Adam Carbolito, Director of Policy and Advocacy at the Association of Asian Pacific Community Health Organizations, or APCHO, and I'll be serving as today's moderator. APCHO is a national nonprofit membership association dedicated to promoting advocacy, collaboration, and leadership that improves the health status and access of Asian Americans, Native Hawaiians, and Pacific Islanders within the United States, the US territories, and the freely associated states. Primarily through our member community health centers, APCHO is a national voice for policy change to ensure that communities have better access to affordable, high quality, and culturally and linguistically proficient healthcare. Together with my co-chair, Ian Rick John, with the Asian and Pacific Islander American Health Forum, whom you'll hear from later, I co-chair NCAPA's Health Committee. A few housekeeping items. This workshop is being streamed live and recorded. All participants are currently muted, and if you have questions during the presentations, please type them in the chat box. We will have a question and answer segment following the presentations. The Asian American, Native Hawaiian, and Pacific Islander communities are the fastest growing demographic group in the country, with a total population of over 22 million people who trace their heritages to over 50 ethnicities speaking more than 100 different languages. In 2018, there were more than 11.5 million AAPIs of voting age, and our communities continue to grow. Our community's diversity is our strength, and we are harnessing our political power to effectuate positive change at federal, state, and local levels. Yet as the nation confronts the challenges caused by COVID-19, health disparities that have long been present in our communities have been exacerbated. Today, we will discuss long-term health policy priorities for the AAPI community and immediate interventions that we can take as we fight the pandemic. To get us kicked off today, I'm honored to introduce Congressman Ami Bera, who represents California's 7th Congressional District in the US House of Representatives. A first-generation American born and raised in California, Congressman Bera is an MD by training who during his 20-year medical career was a champion of improving the availability, quality, and affordability of healthcare in California. Congressman Bera was elected to the US House of Representatives in 2013 and is currently the longest serving Indian American in Congress. Congressman Bera is a member of the House Foreign Affairs Committee, where he serves as chair of the Subcommittee on Asia, the Pacific, and Nonproliferation. He is vice chair of the House Committee on Science, Space, and Technology, and serves as co-chair of the Congressional Asian Pacific American Caucus Healthcare Task Force. Congressman Bera, thank you so much for joining us, and I'll turn it over to you.
Adam, thank you for that introduction. Yeah, I'm gonna couch my comments a little bit as a member of Congress, but a lot as a physician and an Asian American myself. You know, well, let's actually start from the physician perspective and, you know, just thinking about it. Far too often, you know, when people are talking about the Asian American community, they're not disaggregating who we are. They're thinking about us sometimes as a monolithic community, and you'll often hear terms like, oh, model minorities, et cetera. But the truth is, if you dig deep into our broad community, and Adam, I think in your opening comments, you talked about the number of languages spoken, the different religions and everything. We're a very diverse group. And here in my own home district, you see that diversity and you see that lack of access to healthcare, et cetera. You know, also, you know, if we think about, you know, some of the issues that are difficult to talk about, particularly if I think about my parents' generation, that was the first generation that immigrated from India, but that first generation, you know, issues of mental health often become taboo and difficult for people to talk about in our community. LGBTQ issues become difficult to talk about. in the broad community. Domestic violence, things like that, all of these stressors. Plus, if you think sometimes of the pressure that we put upon ourselves, as well as the pressure that gets put upon our children, that also disproportionately often impacts things. Now, that's all going to be exacerbated under this public health pressure of the COVID-19 pandemic, but also the economic challenge that many of our families are going to face and many in the community will face. And if we don't proactively, as a community, create space for us to talk about these issues and surface the issues, create the unique support structures to deliver culturally competent, language appropriate care to these communities, I think we will have a lot of morbidity, disease that goes untreated, a lot of mental health and stress and pressures. And I think it's important for us to be able to have those conversations and create those contexts where communities can have them. But again, we're not a monolithic group. So it may be one way that you have to approach the Indian American community, a different way where you're approaching the Hmong community, understanding the cultural mores, a different way that you approach the Chinese American community. And I think that's the complexity when you look at the broad Asian American, Native Hawaiian, Pacific Islander community. Again, we have to be sensitive to the different ways to approach it. That's why I am such a strong believer in the community health center model of treating health, because you can take that down to the neighborhood. And the one thing that you do see in a lot of our neighborhoods is that cultures will come together. So here in Sacramento, we know where the Hmong and the Vietnamese community have kind of congregated. You see the Koreatowns, the Chinatowns, et cetera. And one thing we should be doing as Congress, I'm a real strong believer in, is how do we better support community health centers that can then adapt to the culture, the language, even kind of hiring community health workers out of the community. So you have trusted individuals that can, go out there. And it's, again, going to be different in different communities. We've done that in the past where you may approach a Muslim community differently on issues of breast cancer screening, et cetera, and you have to understand the cultural competency than you would approach another community. And I think that's going to be very important. Now, the silver lining that I see, and I'm seeing it in some of the rallies and the protests post the George Floyd murder, is the number of young Asian Americans that are out there. And it's not just Asian Americans, you're seeing young Caucasian Americans, and it's that broad diversity. But as an Asian American myself, it's exciting to see the next generation really getting engaged, speaking out, and getting involved. And that gives me a lot of hope. The conversations that may have been difficult for my parents' generation, and that maybe we're starting now, they're not a problem for the millennial generation or the generation that was born and raised here, that has always felt like they had a seat at the table. And they're giving voice to those issues. Again, whether that's mental health, whether that's domestic violence, and that's something I talk about a lot in my own South Asian community, because I think it's epidemic there. LGBTQ issues, all of those. If we can't talk about it, we can't bring it out of the shadows and create a safe place for us to discuss it. So, thank you to all the Asian American, Native Hawaiian, Pacific Islander groups that are having forums like this and coming together, because every year that you have events like this, we continue to grow. And just as in Congress, CAPAC, the Congressional Asian Pacific Islander Caucus, has continued to grow, and we're at a record number of API members of Congress. And when I look around the country at the number of folks that are running, I think we will continue to expand that focus. And it's important for us to be at the table as well, representing the broad community, so we can give voices, legislations going through to make sure that we're recognizing the unique healthcare needs of the AAPI Native Hawaiian community. So Adam, thank you for inviting me and allowing me to say a few words. And again, I'm very optimistic as we move forward that we will find the courage to have these conversations and come together as a nation and a world.
Thank you, Congressman Barra, for your extraordinary leadership in the House and for all that you do for our communities. I think it's absolutely right. You're absolutely right that it's imperative that we tailor our interventions and how we respond to the needs of our communities based off of what our communities really needs that is culturally and linguistically appropriate and accessing healthcare. And we very much appreciate your time today in joining us, and we hope to continue to work with you as we move forward.
Thank you.
Since 2004, the National Council of Asian and Pacific Americans has developed a policy platform that is presented to presidential candidates and the public at large to make policy recommendations related to the Asian American, Native Hawaiian, and Pacific Islander communities. As Congressman Barra said, our diversity is a source of strength, but it also poses unique complexities, especially in accessing and delivering healthcare that is affordable and appropriate to an individual's unique circumstances. The NCAPA policy platform seeks to introduce federal policies on how to address the unique issues that are experienced by AAPI communities across the nation. And so now I'm pleased to turn it over to my NCAPA Health Committee co-chair, Ian John, the Senior Policy Strategist at the Asian and Pacific Islander American Health Forum, to provide an overview of the NCAPA policy platform. Ian, over to you.
Thank you, Adam. Thank you for that introduction, and thank you all for joining us this evening and afternoon, wherever you're joining us from. Again, as Adam mentioned, my name is Ian Rick John, and I serve as the Senior Policy Strategist at the Asian and Pacific Islander American Health Forum. For those of you who are not familiar with the Health Forum, we are a national health policy and advocacy organization based in Oakland, California, with an office in Washington, D.C. Our focus is on improving the health of Asian Americans, Native Hawaiians, Pacific Islanders living in the US and its territories. We have been around for about 35 years, and we really pride ourselves on impacting federal level policy, connecting ourselves to community organizations on the ground, and making sure that stories and the experiences of the communities that we serve are part of the discussions at the federal policy level. We are involved in training and capacity building as well, and we serve a network of over 100 organizations in about 35 states across the country. So what I wanted to do today is just give you a little bit of background about the policy platform, and I'll ask Adam to go to the next slide. I wanted to just give a background about the policy platform itself, and specifically the health-focused priorities under the 2020 NCAPA policy platform. So as Adam mentioned, this is something that the NCAPA does in leading up to the presidential election every year. The policy platform provides a comprehensive set of policy recommendations related to AA and NHPI communities. The different issue areas mirror the different NCAPA committees. So there are committees that focus on immigration, health, civil rights, education, housing, and economic justice. And this year's platform also includes a section on technology, and given our current world, specific recommendations related to COVID-19. So the policy platform itself is developed based on feedback from all NCAPA member organizations, and the health committee itself includes probably about 11 or 12 organizations. These include organizations like Appeal or APCHO that Adam represents, NAPHOV, JACL, EPIC, Napa FASA, represented by Myron today on our call, and several other organizations. And the health policy priorities are really based on the priorities of the member organizations, as well as the community partners that the member organizations work with. So we really pride ourselves on trying to make sure that these priorities are in alignment with the priorities of our organizations, as well as the communities that we're serving. And if you see on the screen here, I also included the link to the policy platform document itself. This is found on the NCAPA homepage under resources and then under NCAPA policy platform. So you can go there to the website, you can see the full document, which is about 60 pages long, as well as some one-pagers on the different sections, including the health section. So I'm leaving that there as a resource for you when you have time to take a look in detail at the policy platform. Next slide. So today I just want to give a brief overview of some of the content and recommendations that are included in the health section of the policy platform. So the first sections really focus on expanding access to care. This includes rolling back some of the recent expansions of the public charge definition that impact the ability of immigrants to gain legal permanent resident status if they use certain benefits. It also includes removing the 5-year waiting period for many immigrants before they are able to be eligible for Medicaid. And we also include support for the Navigator program, which provides funding for community-based or community organizations to help people understand coverage options and enroll in and use their health insurance plans. And as was mentioned, you know, the trusted organizations on the ground that are helping communities enroll in coverage are those that really need funding. And so one of the key areas that we have in here is support for the federal Navigator program. The second section, next sections kind of focus on reducing health disparities in a number of ways by enhancing culturally and linguistically appropriate care, by improving collection and the reporting of disaggregated race and ethnicity data to better understand and address health disparities. And also this includes advocacy for federal programs that provide dollars to support these efforts, such as the CDC REACH program, which is the racial and ethnic community approaches to health. You'll see that we also promote policy solutions through several pieces of legislation at the federal level, including the Health Equity and Accountability Act, as well as the HEAL for Immigrant Women and Families Act. Next slide. So the health section also focuses specifically on addressing hepatitis B because of the large disproportionate impact it has on our communities. And so we have components in there on advocacy, on recommendations to increase funding, as well as to oppose institutional discrimination based on hepatitis B status. Another piece of the policy priorities includes reproductive health and rights. So supporting the right to abortion care and the removal of abortion bans at the state level, as well as reversing administrative actions that allow employers to restrict access to affordable contraception. We also include a section on ending gender-based violence. So this includes support for funding for culturally and linguistically appropriate outreach, prevention and services, as well as protection for victims from deportation. And the support is we include through reauthorization of the Violence Against Women's Act, as well as the Family Violence Services and Prevention Act. Next slide. So the health section also includes a component on Native Hawaiian and Pacific Islander health issues specifically, and I will turn it over to Adam to talk about some of those specific policy recommendations that fall under the Native Hawaiian and Pacific Islander health portion of our priorities. Adam, I think you're on mute still.
Thank you, Ian. Appreciate that initial overview of our policy priorities. And as Ian mentioned, we do provide specific recommendations on how to improve Native Hawaiian and Pacific Islander health throughout the country. Oftentimes, NHPIs are excluded from federal policies, or they don't receive proportionate support in federal programs. So NCAPA's policy priorities does propose to strengthen and reauthorize the Native Hawaiian Healthcare Improvement Act through 2029 and provide that 10-year extension to provide better access to healthcare services and community programming, increase representation of Native Hawaiians in healthcare professions, and improve the availability and expand the availability of traditional healing and other complementary practices for Native Hawaiians. We also propose, and we strongly recommend, the restoration of Medicaid eligibility for COFA citizens. COFA citizens are Pacific Islanders from the freely associated states of Palau, the Marshall Islands, and the Federated States of Micronesia, who have special relationships, compacts of free association, which are basically treaty agreements between the United States and these three island countries. In exchange for the United States maintaining strategic military presence in the Pacific, the United States allows COFA citizens to come to the United States for healthcare, education, and for work without the need of a visa. However, since 1996, COFA citizens have been categorically ineligible for Medicaid, which has caused significant harm and reduced the ability of COFA citizens to access our healthcare system. So we recommend that Medicaid eligibility be restored for these individuals, particularly given the history that the United States has in these islands, including some of the nuclear weapons testing during the Cold War that led to many of their islands being uninhabitable and significant increases in health disparities among Pacific Islander communities from the freely associated states. Lastly, this is something that I think we've seen in the last couple of years get more attention, but health programs and federal programs in general that are administered within the U.S. territories are often not provided equitable support to the programs that are administered in the states. One critical example of this is that Medicaid in the territories is administered as a block grant, per capita block grant, which significantly impedes the ability of territorial governments to extend Medicaid access to island residents in Guam, the Commonwealth of the Northern Marianas, American Samoa in the Pacific, and then also the US Virgin Islands and Puerto Rico in the Atlantic. So what we are encouraging is the removal of these inequitable funding caps and federal reimbursement limits for the US territories and extend eligibility for healthcare programs, including permitting Medicaid disproportionate share hospital allotments in the territories. We think that it's absolutely critical that US citizens and other residents of the US territories have equitable access to healthcare regardless of where they live. And currently the health programs within the US territories is significantly impeded because of these policy deficiencies. So that is a summary of the NCAPA health policy priorities. And now I want to turn it over to my good friend to talk about some of the work that she's been doing on the ground in Oakland, California. So next, we are going to hear from Dr. Tu Quach, who has been an ardent advocate working in public health and healthcare for over 2 decades. Her research, service, and advocacy work has been grounded in her own lived experience as a refugee from Vietnam and the struggles her family faced in the healthcare system. Trained as an epidemiologist, Dr. Quach has conducted numerous community-based research focusing on Asian Americans and immigrant populations, including examining occupational exposures and health impacts among Vietnamese nail salon workers. This work was inspired by her own mother, who passed from cancer at the age of 58 after working as a cosmetologist for decades. These findings have contributed to the seminal work of the California Healthy Nail Salon Collaborative, which has shaped policy changes and worker rights and safety. Dr. Quach currently serves as Chief Deputy of Administration at Asian Health Services, a federally qualified health center in Oakland, California, serving 50,000 patients in English and 14 Asian languages. She is involved in local, statewide, and national research and advocacy efforts to promote health equity. In 2017, Dr. Quach helped Asian Health Services form One Nation, a national coalition of over 100 organizations working to galvanize the Asian American and Pacific Islander community around the issue of public charge and its impacts on immigrant families for using vital services such as healthcare, food, and housing assistance. Thank you, too, for joining us.
Thank you, Adam. I didn't expect you to read the whole bio. Thank you so much. Again, I work at Asian Health Services. I'm so proud to be working here, especially during this time. We are a community health center in Oakland, California, serving 30,000 patients, providing primary care, dental, and behavioral health, as well as a whole host of preventive and community services. We have really been with the community since our founding in 1974, and started by the community when others were not addressing the many needs among Asian Americans and Pacific Islanders. So when this pandemic hit, our organization responded in the ways that we've always responded when something hits, to ensure that our communities are served, that they're not invisible, and that their needs are lifted up. Next slide. So when COVID pandemic hit, I would say that so much had been happening for decades, but in particular during this period, it was a perfect storm. You have the public charge policy that had passed and was implemented on February 24th, right before all of this hit in March for our nation. There were rising Asian American attacks, really blaming our communities for this virus, which they thought was coming from China, but really it was all across in other countries as well. But the focus had been on blaming our community. And then COVID really hits here in the US in March. And then you see the aftermath of that happening as places were closing down. But before that, in Oakland, Chinatown, where Asian Health Services is located, as well as throughout our county, we saw restaurants closing down, not just because of safety, but because of fear of being attacked. We saw our own communities wearing masks even before it was required, before shelter in place was happening, because our community understand what it's like to really protect ourselves as well as protect others. But at the same time, they were being discriminated and targeted for that. And then all across the nation, we saw as COVID was hitting that there were barriers to getting testing. There was not enough tests. And even among our healthcare providers, there was not enough PPEs. We were relying on the generosity of our own community members, like nail salon workers, like the Committee of 100, to really donate to us to ensure that we can continue to serve our community. And then as shelter in place happened, as the nation was starting to shut down, unemployment was rising and our community was just greatly impacted. And on the ground, as a community health center, we basically saw our community go into hiding and really, really be fearful of what was happening outside. Next slide. I was asked to share some patient stories, and our health center gathered hundreds of stories, really powerful to hear, and I'm just pulling from a few of them. We saw firsthand as this was beginning in early March, as schools were shutting down, our own youth approaching our staff, asking where they can get their next hot meal, not knowing what was going to be provided for them. We saw our own HIV patients with immunocompromised systems not able to go out to grocery shop because they were afraid of what it would do for them, and our staff stepping up to help out. We had one patient, and this really was so painful to even share, who shared that one of our doctors shared that she had been wrestling with so many issues, and then this COVID and her losing insurance pushed her over the edge, and she tried to commit suicide. Fortunately, she was unsuccessful. She was hospitalized, and our staff worked to stabilize her. But this is what was happening when people are pushed to the very edge. And we heard so many stories, one in particular of a single mom who was undocumented, who lost her job, and she actually had two children who had specialty mental health needs, and she was really fearful of being evicted from their homes. This was what our communities were faced with as the pandemic hit them. Next slide. Stories after stories of reporting of anti-Asian hate. Many of it underreported, but we knew that it was on the rise. Next slide. I wanted to share just a few stories from our own patients. And we had so many of these come forward from our staff. An elderly patient who was taking the bus and was being yelled at by the bus driver and told to go sit in the back of the bus. Of families who would go into the grocery store and were being harassed so much that they stopped going out and just hid in their homes. Of a patient who was walking down the street and just got kicked by somebody just for being Asian. And then so many people saying that as they're wearing masks to protect themselves and to protect others, they were being yelled at. We had one incident where our staff reported that a car drove onto the sidewalk trying to hit an Asian woman in front of her grocery store. And if it weren't for the fact that she had boxes of produce in front of her, she would have been injured by the car. These are all just examples of the many hate crimes that were being targeted in our community, yet it was not being brought up and lifted up. Next slide. And at the same time, as a community health center, we had to rapidly respond. Overnight, we had to transform ourselves in order to serve the needs of our community. Our visits, because of the shelter in place, went down to 9% of what it was prior to COVID hitting. And yet we had to make sure that our staff can work from home, make sure that we transform ourselves to be able to do telehealth so that our patients can continue to be cared for, created new protocols and workflows, and really worked hard so that within weeks we were able to bring that volume up to 80% of what it was before COVID hitting. All of this was happening rapidly as we were dealing with patients' concerns and even with our own staff concern. And I just wanted to highlight that picture that you see on the bottom right of our elderly patient. She's in her 90s, and we were able to get her to learn how to use her phone so that she can see her doctor, our Chief Medical Officer, Dr. George Lee. This is the type of work and dedication and really innovative thinking that our staff were primed to do and really handled it as COVID hit so that we can respond to our patient needs. Next slide. And this is a fun one from our dental staff, being concerned, but knowing that our community still had needs. They created a drive-through that allowed them to apply these dental varnishes, these sealants, on pediatric patients. These are required for them before they entered kindergarten. And we knew that while COVID hit, we had to continue to provide for our patients and continue the care that we had. And it really just shows the innovation, the dedication of our nearly 500 staff at Asian Health Services. Next slide. But regardless of what we did, I do want to say that we still met with challenges of data, limited data, small numbers, hidden disparities that always happens to our community. So these are numbers from our Alameda County where Asian Health Services is based. And on your left-hand side, you see the total number of cases. And you see the Latinx community having a lot of cases, and then a group of unknown who I suspect has a lot of Asians in it, and then Asians number of cases. But the way it gets reported is by case rates. And because we know that a lot of Asians were not coming forward to get tested because of fear, because of all the anti-hate that was going on, because of everything that was happening to them, all you see is these really low numbers. And then on the flip side, on the right-hand side, you see the death rates. And again, Asians don't look like they have high death rates compared to the other groups. And again, it looks like it's still fitting into that model minority myth that we're just not affected by this pandemic. Next slide. However, I've been working with a really awesome group of researchers from across the country. This group has been led by some UCSF leaders as well as those from UCLA. Dr. Tung Nguyen, who many of you know, has been leading that. And they publish a lot of what's called case fatality, the number of deaths over the number of COVID cases. And we're seeing again and again across different states, across different areas, that Asian Americans, as well as Pacific Islanders, have case fatality rates that are higher than the overall population. This is an indication that there could be lack of testing that's being done, or disease severity, or both. But it's important to see that we need to lift up these disparities and show the data in the way that it should be shown to highlight that our communities not only have needs, but are suffering from a lot of these disparities. Next slide. And as you think about COVID, I think the focus has been on who has it and who doesn't, and the numbers and such. But really, the way to respond to our community is really stepping back and taking a comprehensive view. And that we've laid out 4 areas that we think needs to happen. The first is, it's not just the idea that if you build a testing site that they'll come. There are other factors that really affect whether a person is willing to go forward and get tested. We've seen this happen before with other disease outcomes, like cancer screening, like HIV, like smoking cessation, that really there are other factors that affect whether someone will come forward. With COVID, you see that deep outreach and education needs to happen, that you have to consider language, you have to consider culture, immigration status, especially in the era of public charge and all that's been going on, and everything else. And then that gets them, when you're addressing that through culturally and linguistically specific outreach and education, then it gets them towards testing. Once they get tested, the idea of contact tracing to really limit where it gets spread needs to be done, but it needs to be done with a lot of considerations to other factors, like who is the trusted entity and language and culture. As a community of immigrants and refugees, imagine getting a call from a local county government saying, hey, you've been in contact with someone that has COVID. That can be really scary. And so, you know, we're working and pushing our county to work with the many trusted sources out there and be really thoughtful in how we handle the situation so that our communities don't go into further hiding. And then what happens once they do get diagnosed? There's a number of needs that they have in terms of case management, in terms of support, housing for someone who needs quarantine and are living in overcrowded housing with not just their families, but others as they share housing, mental health support. We really need to expand how we're looking at this rather than being siloed in our approaches. Next slide. This slide just shows you the many different languages, and Representative Amibero talked about our diverse communities. This is some of Asian Health Services patients, and you can see that while there's a large number of Cantonese speaking patients, we also have all these other smaller communities. Each of these communities needs specific outreach that really pays attention not just to the language, but to the cultures and to all the other things that these communities are facing. So it's really important that we're thoughtful in how we design these programs. Next slide. Asian Health Services, I can tell you, has been really hard at work. Not only have we continued to provide the many medical, dental, and behavioral health services, but we've been out there in the community. We really put out outreach materials, created and revamped ourselves so our patients can call in, our community can call in, sending language-specific materials. When no one else was doing it, we really knew that our community needed that information so that they're not impacted by a lot of the misinformation. We started a WeChat account to get to our Chinese community. We were creating videos in language and really checking in with our vulnerable population so that they get the case management and services that they need. And then really partnering with many of our partners. Next slide. This is just a list of the 14 partners that we're immediately partnering with in terms of addressing COVID, understanding that they themselves have really built an infrastructure and are trusted entities within their community. Last slide, please. And I just wanted to end to say that, you know, as we are addressing this huge pandemic, you know, we've been here before. It was a different issue, a different disease, a different health outcome. But the idea that we're simultaneously blamed and yet overlooked when it comes to the needs, I think this is something that we have to think strategically and work together to ensure that our communities do not go into further hiding. And then it comes out as the same old narrative that we don't have the problems when we know on the ground that we're seeing that our communities suffer. And I think that I really look to all of us working collectively together on this area. So thank you.
Thank you so much too for that incredible presentation, really grounding us in the experiences that our communities are experiencing right now, especially in COVID, but really the challenges that you've been seeing as a provider at Asian Health Services, and really like what those challenges are. Next, I would like to introduce our next presenter, Myron Kwan, the Executive Director of the National Asian Pacific American Families Against Substance Abuse. NHPIs is the country's national nonprofit that prevents and reduces substance use disorders and behavioral addictions in AA and NHPI communities. Mr. Kwan manages its programs, including national and local advocacy for language access and cultural competency, gambling addiction training, and public policy concerning alcohol, tobacco, and other drugs. Before NHPIs, Mr. Kwan was Executive Director of the Asian Pacific American Legal Resource Center, where he supervised attorneys and community organizers focused on empowering low-income Asian immigrants in DC, Maryland, and Northern Virginia. Mr. Kwan was the inaugural Legal Director of Advancing Justice Chicago, where he successfully led advocacy efforts to repair the resumptive exclusion of Asian American-owned businesses, enterprises from the City of Chicago's Public Contracting Affirmative Action Program. Mr. Kwan's experience includes working as a program officer for the Chicago Community Trust and as Deputy Regional Director for Lambda Legal, focusing on civil rights issues impacting LGBTQ plus people and people living with HIV/AIDS. Myron, thank you so much for joining us, and I'll turn it over to you.
Okay, great. Thanks, Adam. Am I clear and everything working right now? It looks a little sketchy on my side. Everything's good on your side?
Yes.
Okay. Unfortunately, I can't see the slides that you're presenting, but I will move forward as is. I'm going to move on to the first slide, which I think is the one, just a quick blurb about FASA, just indicating that, again, within the country, we are the only nonprofit that's focusing specifically on behavioral health issues and Asian Americans, Native Hawaiians, and Pacific Islanders. And within that, we obviously focus the most on alcohol, tobacco, other sorts of the bread and butter issues, including synthetics at EDMs, what have you. Next slide. So again, we already have heard repeatedly now at this point about how Asian Americans, Native Hawaiians are unique in terms of some of our challenges. The uniqueness includes the fact that we are a very fast growing population, but yet we use mental health care at a very low rate compared to everyone else. And then even worse when it comes to, because we are so diverse in terms of language and culture, when we try and do anything that's even close to culturally or linguistically appropriate, we're not even close to there just because we don't have the education, the outreach, or even implementation that's necessary to do the right work. And then lastly, as we've heard repeatedly, when it comes to Asian folks and mental health issues, between stigma and all sorts of other issues, it's just not happening when it comes to Asian folks and Pacific Islanders and Native Hawaiians. Next slide. So I wanted to just do two quick slides to provide just a baseline, because again, even though many of us on today's panel have some awareness of Asian folks and our disparities, it never hurts to go through some of the basic ones. One of the ones I almost always talk about, and I think is now more common knowledge, is again that when it comes to suicide rates among Asian Americans in general, we don't think about Asian people in suicides, but actually when you look at Asian American females between the ages of 15 to 24 and Asian American seniors, they have actually the very high rates of suicide. So that's, you know, example one that we try and use, but yet may not ever be covered by mainstream media. When it comes to also like Bhutanese folks, same thing. When you look at suicide rates among the general population, it's only about 12 per every 100,000, is more or less twice that when it comes to Bhutanese. And again, it could be likely very much higher than that just because of underreporting and stigma talking even about suicide, something we never talk about. Other factoid involving young people, just looking just in Hawaii, when it comes to Native Hawaiian youth versus those who are not, again, when it comes to suicidal ideation, it's much higher among those who identify as Native Hawaiian versus not. Next slide. And again, these are all, again, for those who are within the group, when we talk about these issues, the disparities, these are not that surprising, but again, perhaps surprising some of the folks on today's panel, attending the panel, would be just looking at Cambodian Americans, just having very, very high rates of depression, PTSD. Oftentimes we get this right by doing more community-based research, right? If we try to do it non-community-based, we won't get these numbers, but if you do community-based, you can just see very high rates of depression, PTSD versus general population in the United States. Same thing again when you're looking at Southeast Asian students. So again, you could be talking about those who are Hmong, Lao descent, Vietnamese, what have you. Again, very high levels of secondary trauma. And again, when you talk to folks in Orange County or in San Jose, right, we are always thinking about perhaps it is intergenerational trauma, and that's part of what we're dealing with when we work with our young folks. Again, to already start talking about all the types of anti-Asian incidents that are out there. One type that's been around for quite a while, actually, as we know, is just the basic bullying of Asian American students and happening at school. And again, we could talk about, you know, people oftentimes want to say, oh, it only happens, you know, in rural parts of America, and definitely not. Like even in Baltimore City, definitely there's a large Bhutanese, Nepali community out there. And again, I've heard the actual stories of just being bullied and just for being immigrants, being different and not speaking English well, right? So this is like real stuff that happens not just in rural America, but also in urban parts of the country. And then lastly, is we have all hinted at different points when it comes to mental health, we have to be aware that many of those who are Asian American also identify as being Muslim American. And ever since 9/11 and just progressing onward ever since then, there's just been a lot of anti-Muslim incidents. And again, when we tried to have that ban, that even increased the amount of Islamophobia as well back then. Next slide. So those are just some basic examples to provide backdrop in terms of why this is happening. Again, you've already had it hinted at by some of the prior speakers. One of the issues that we all face as Asian Americans in particular is the so-called minority myth, where they just jumble us all together. We're going to do great. We're going to go to Harvard, and we're going to get 4.0 GPA and what have you. Definitely not true, and it can have negative effects at least two ways. Number one, you definitely have kids who are, good performers stressing out because they aren't getting the straight A's and also doing the violin or what have you. Those folks aren't doing well. And then all the other kids who just are like my kids, actually, who are Asian American, just they're not top half. And that's just a reality. And then what does that mean for them to always be living within the so-called minority myth about being good at math and getting great grades and what have you? Definitely, as you speak to community members and school counselors, also the reverse of that, actual negative stereotypes. If you actually work in that part of the country where there are many Southeast Asians or Pacific Islanders, actually the opposite, where there actually is indeed negative stereotyping. There is not uplifting or support or belief in folks who might be of Southeast Asian descent or Pacific Islanders. And in fact, there's more of a, well, you're not going to do well, so let's figure that out. What does that mean, given that that's our expectation? Again, not acceptable when it comes to basic education. The other one, and this again goes back to Tu's comments about all this anti-Chinese sentiment, for many of us, it's the perpetual foreigner issue, right? Just again, the amazing, no matter how long you've been in a city or in a state or being born and raised in the United States, there's always this assumption that you are a foreigner, you don't speak English well naturally, you should have an accent, and you have an allegiance to another country. Just this bizarre, world that we live in that creates microaggressions and cause all sorts of mental health issues, just always having that come upon you. Again, we already spoke about bullying and harassment, and beyond schools, obviously, we could just talk about TSA, whether we like it or not. For those of us who are of Asian descent, oftentimes there is travel to other countries, and if that's the case, then TSA can also come to the mix. Lots of reports over the years of SFO, JFK, and even LAX as the TSA agents literally harassing people who are coming from, say, Hong Kong or China and just being treated differently for absolutely no reason. And again, I think the behavior happens a lot because they believe, and sometimes they're right, that Asian folks aren't going to rock the boat and make a complaint if they are being harassed by TSA agents. Other background issues, just basic trauma again. Many of us are refugees. Many of us are survivors of genocide, at least whether it's World War II, what have you. And so trauma is just a part of the background for many of us who are here. And then lastly, just this hot, very much a bimodal distribution when it comes to our rates of education, even within one ethnicity. But then if you start looking at all the different sorts of folks who identify as being Asian American, Pacific Islander, and Native Hawaiian, it really is just like a huge spectrum of getting 2 PhDs versus not being able to even complete your GED. And if that's the case, that also is just shows the diversity of our communities. And so that's sort of the background in terms of where we're at, just thinking about mental health issues before we even got to COVID-19. So there's 2 more slides I just want to talk about, and then I want to make sure that we have some chance for a little bit of interaction with the audience. The main one is, again, I go back to, I must call it out. I will go back to our current administration, our current administration is not afraid to talk about coronavirus or COVID-19 as being Chinese virus or common flu. And again, also just all these hatenesses involving Asian American healthcare workers who are essential healthcare workers. To make it even more complicated, because NHPI is based in the San Gabriel Valley, we not only do we see a lot of anti-Asian behavior by all folks within the country, within the San Gabriel Valley, we actually see very specific anti-Chinese behavior by those who are of Asian descent who actually know enough to actually say, oh, you're Chinese, or you're Vietnamese Chinese, or you're not Chinese. And so just this very which is not acceptable, right? We don't want there to be actually sophisticated ways of looking at having hate incidents occur. Other things that have also occurred, obviously, with the uprisings. There has been triggers. We've heard from many people, those who have survived genocide, survived war, even those who have survived Koreatown. Right now, again, it's just another time of a lot of triggers for them as well. Ray mentioned the issue of a person who might have HIV/AIDS. For those of us who have lived through HIV/AIDS, every conversation of are you positive, are you negative, it's just a lot of triggers for those of us who have survived the HIV/AIDS epidemic. And then last slide, which you may not be able to see, I just realized when I shared it with Adam. Hopefully you can see it. If not, I will just go through quickly. The main issues are, when it comes to our elders, they've always been at risk for greater social isolation due to language and not wanting to go out. So now with COVID-19, to share the example of trying to get their CMO to interface with just basic telemedicine, but that is a real challenge. My mom lives in Alhambra, and she is bored out of her mind in her seniors housing where nobody talks to each other really, nobody, they're all WeChatting, so that's good, but they are really isolated right now at this moment. Other issues include the Black Lives Matter issue, and whereby, again, because of the way most Asian Americans, Native Hawaiians, and Pacific Islanders, the way we're built, we don't rock the boat, we don't challenge our elders, and yet that is sort of what is necessary right now for sure in terms of conversations, in terms of what we need to do as a country, so that can create greater stress for everyone. Last 2 points involve just the many wonderful therapists are doing telemedicine at the moment, but they are definitely suffering from compassion fatigue and then just the strain of telemedicine itself. It is not easy to do more than 30 minutes of one-on-one sessions with a person via Zoom, especially if you're isolated as well, not able to do the breaks that you could do when you had a practice that was pre-COVID-19. Last example that I just wanted to share has to, again, goes to us understanding what does it mean for us to be in COVID-19 as Asian Americans. And I'm going to use the pandemic EBT example. For those who aren't aware, if your child gets either free or reduced lunch in the public school system between now and the end of June 30, by June 30, if you have not received any sort of EBT by now, at this point you should have gotten a card or some sort of notice, you need to go ahead and apply and try and get your $300 plus to make up for any EBT, any sort of lunches and meals that you normally would have gotten at school. The reason why I raise that is, two specific issues. Number one, CDSS, the California Department of Social Services, tried its best to claim that it's not a public charge, that meaning that if you are going to get a PEBT card, you're not public charge, but they didn't do a great job of explaining that. And that's, again, where, too, and all the work she's done and all of us in the room, we've done our best to talk about how, no, it's not a public charge. You should apply, you should get that money. And number two, language access. Even here in California, here we are just a few weeks to the end of June, and it's only available, the languages are only in English, Spanish, and Chinese. That said, we are lucky that we have some very strong California advocates who have pushed back with CDSS, and they've now extended the deadline to mid-July, so that is a little bit better. But again, for those of us who are working with low-income families, that's a real issue. And what we're seeing is the issue of both public charge and people not wanting to apply or being scared of applying, number one. And then number two, again, just always goes back to cultural competency and language access. And for sure, when it comes to this basic, really critical amount of money, those who are greatest need, I'm sure, are not aware of it. And it's our job to try and push government to do better, and our job as advocates to try and get the information out there. And that's my last comment.
Thank you so much, Myron. If folks have questions, please go ahead and include them in the chat box now. We'll see if we have time to get to them. But one thing that I did want to ask from the two of you is, first, thank you so much for your presentations, but what are some possible policy solutions that should be advanced to address some of the mental health issues that I think both of you have raised? Are there any examples of encouraging policies being proposed or implemented in California that you've seen?
Myron, did you want to go first, or?
Yeah, I mean, I'll just go quickly. I mean, so Judy Chu, she's our champion. she's been consistently trying to reduce stigma among Asian Americans and consistently trying to ensure that when it comes to mental health services and funding, that we fund more at the local level. And so that was what we heard earlier from Congressman Barra. I mean, that is a part of the solution. How can we create the greatest possibility that when it comes to access and when it comes to cultural competency and language, that mental health services are being provided at a local level and that they're truly partnering with community-based organizations to make it happen. I mean, that's been our dream forever. And that's something that we're still not quite at yet. And I work very closely with LA County and we're not there yet.
Yeah, I would just add that, you know, at Asian Health Services, we have, we provide a lot of mental health services. And during this time, you know, I just did a survey with 1,300 community members. And, you know, there is such high need. Probably almost everyone that responded to the survey are suffering from depression, stress of some kind. And yet, even before this hit, there was a huge shortage in bicultural and bilingual mental health professionals. And we just need to invest in that and not just assume that by using a language line that you're going to be able to serve that. And when you have a community that's already stigmatized and now suffering from so much, you know, we really need to expedite all that we need to do for the workforce, as well as supporting that workforce so that they're not suffering themselves. And I have to say that, you know, on our end, the payment system for mental health really is bad. And so this is the time to do it and do it quickly.
Thank you so much. Another question that we received is, what is something that we can do as the public to help advocate for language accessibility to healthcare in our communities?
You know, I think that that's going to take a while in terms of explaining and answering, but I have to say that, you know, the fact that we've had all these language access successes, we need to ensure that that's happening at the testing sites, through the contact thing, all of that still applies. Just because we're in a pandemic does not excuse anyone from not having these language accessible places. And instead, they're calling upon others to come in
Right.
and translate for them. And I think we need to ensure that there are threshold languages, that this is by right, and to ensure that that's happening. I think when we deal with things that are happening so quickly, there's always an excuse, well, we just couldn't find that Cambodian worker, but we need to demand that.
Yeah, and the only thing to add on, since that's such a great question, but it really is a state-by-state answer, sometimes even cities, I suppose. You know, Hawaii and Washington, D.C. has really great language access ordinances. So in Hawaii and in D.C., you can actually just file a complaint and move things along. In California, we're only okay. And again, that's, you know, having lived here for nearly 10 years, working as an Asian American professional, and just seeing that, again, you know, I'll just call out. I know I'm being recorded. LA County will tell you, you know, you need to get onto this master list and there's an RFQ, and like, no, this is an emergency and the house is on fire and Asian people are being harmed and you all need to figure out how to get emergency funding. So again, a direct action will be going right to the Board of Supervisors, because they will listen and say, this is not acceptable. Asian people, whether it's a small business owner, young person, a senior, your barriers to entry, your ways of making us do business does not work for us. And Asian people are being harmed during this emergency. So that really is a part of the conversation, not because, again, for those who are interested and want to work on language access, it is, you know, people power. It really is people power. And again, even just one squeaky person complaining to your elected official about what's not working and not working can make a huge difference.
Thank you so much. And it looks like we're coming up on time. If we were not able to get to your question, we will try to follow up with you directly. But I do want to say thank you to both of our speakers and also to Congressman Barra for joining us this evening. And thank you everyone who tuned in tonight for joining today's National AAPI Leadership Summit Health Workshop. I hope that you will engage and join APIA Vote and CAPA throughout the week as we explore other critical issues for Asian Americans, Native Hawaiian, and Pacific Islander communities. I also hope that you will join us on Saturday, June 27th, for the 2020 AAPI Presidential Town Hall, where we will directly engage with Vice President Joe Biden and former Governor Eddie Calvo from Guam as a surrogate from President Trump's campaign. The Presidential Town Hall will be broadcast live at 3 p.m. Eastern, and you can find out more or register for the Town Hall at www.apiavote.org/townhall. Once again, I want to thank every one of our presenters, Congressman Barra, Quach, Mr. Kwan, and my health committee co-chair, Ian Rick John. Everyone, please stay safe and healthy, and be sure to register and get out to vote in November. Thank you and goodbye.